Welcome to my session on online surgery class. Today's topic is on peripheral arterial disease. Now, peripheral arterial disease, there's got two parts to it. The first part is the chronic limb ischemia. And the second part is your acute limb ischemia. Okay, although both are related, but the presentation are very different, especially the acute, the presentation is very acute. Okay, so we shall discuss these topics in briefly, go through the causes, the clinical signs and symptoms, and also the investigations and management of this condition.
Okay, I will begin with part one, in which we will talk about chronic limb ischemia or CLI. Okay, chronic limb ischemia is a form of peripheral arterial disease that results in symptoms due to reduced blood supply to the limb. Okay, it is typically caused by atherosclerosis, rarely by vasculitis. Most common is atherosclerosis and will commonly affect the lower limbs, most commonly lower limbs. However, the upper limbs and gluteal region can also be affected. Around 15 to 20% of individuals over 70 years of age have peripheral arterial disease, although the majority are asymptomatic. The Framingham study reveals the increase in prevalence of the disease from 0.4 per 1,000 males aged between 35 to 45 years. This increases to 6% per 1,000 males when they reach more than 65 years. In this lecture, we shall look at the clinical features, investigations, and management of chronic limb ischemia. Now, what are the risk factors for this disease, peripheral vascular disease? The risk factors basically are smoking, diabetic, hypertension, and history of hypercholesterolemia associated with atrial fibrillation, ischemic heart disease, or cardiovascular accidents. So this in summary. Okay, so these are the important symptoms. These are the important risk factors: age, okay, the leg symptoms, abnormal lower extremity pulsation, and a known case of atherosclerosis. Okay, so to summarize the main risk factors of chronic limb ischemia: atherosclerosis main cause, smoking, diabetes mellitus, hypertension, hyperlipidemia, increasing age, strong family history, and another important one is obesity with physical inactivity. Now, what are the clinical features of chronic limb ischemia? Okay, depends on the earlier symptoms of chronic limb ischemia is intermittent claudication, which is a cramping type of pain in the calf, thigh, or buttocks after walking a fixed distance, which is referred to as the claudication distance. And this pain is relieved by rest within minutes. Okay, so as the disease progresses, the pain becomes constant. Even at rest, the pain is felt. And at this stage, it is known as critical limb or critical limb threatening ischemia. Okay, these are the various stages of the disease and severity by the Fontaine classification for chronic leg ischemia. Stage 1 is asymptomatic. Stage 4 is ulceration or gangrene or both. Okay, so this is the most severe form. Stage 1 is asymptomatic. Stage 2 is intermittent claudication. It's the stage where the patient develops pain on walking or exertion. And stage 3, he gets rest pain, ischemic pain even at rest. Okay, so this is a progressive type of symptoms from stage 1 to stage 4. So patient asymptomatic becomes intermittent claudication. and this claudication becomes worse. Okay, the distance becomes less. Then patient develops stress pain, is the pain even at rest, especially at night. And then later, this can lead to critical limb-threatening ischemia. On examination, what you get in this patient, the limb, affected limb is colder than the unaffected limb. The arterial ulcers may be present, especially in advanced cases. There may be distal peripheral ulcers, reduced or absent peripheral pulse, femoral bruit if there's a blockage or narrowing of the femoral arteries. Okay, this is due to advanced cases. It can be due to femoral stenosis. And the Burgess test, okay, may become positive. This is the excess, the adequacy of the arterial supply to the leg. Okay. This test involves lying the patient supine and raising the leg until it goes pale. Normally, they raise it until 45 degrees. Then lowering them until the color returns or becoming hyperemic. The angle at which the limb goes pale is termed Burgess angle. The angle of less than 20 degrees indicates severe ischemia. So this is a Burgess test, which can be done to assess the one to confirm the presence of ischemia and also to assess the severity of the ischemia. Now, how do you classify the peripheral arterial disease? Okay, this is a simple classification by Rutherford and Fontaine. Two classifications normally used. Basically, it divides the classes, classifies the patient into three main categories. Asymptomatic, okay, here also asymptomatic. Then is the symptoms of claudication. Here, the second stage is the claudication symptoms, where the patient develops pain on walking. Then as the disease progresses, then becomes the claudication becomes more severe until it develops rest pain. Okay, even at rest, the patient gets pain. And lastly, the most severe form is when there's tissue loss, there's ulceration or gangrene, where ulceration and gangrene sets in with sepsis. So this is the most severe form. So basically, 4 stages, as I mentioned in my earlier slide. Okay, these are some pictures showing you this here already having gangrene or ischemic changes here. There is an ulcer, peripheral ulceration on the foot, and here you can see pallor. Okay, this is pale cause of poor blood supply, and here is a normal limb, so pallor. Okay, these are known as trophic signs. Okay, the skin becomes shiny. Okay, there's loss of hair. The nails become brittle. Okay, there's pallor, and there may be also ulcers. Next is so this is the trophic changes that are seen: shiny skin, hairless, tapering, brittle nails, and weak pulse. This is ulceration. Okay, so you can see here ulceration, distal ulceration, these two ischemic changes. Okay, these are known as arterial ulcers, and they are red in color due to inflammation, or maybe black due to gangrene. Deep wounds, okay, they are punch out ulcers. Can you see? They are punch out ulcers, deep wound, deep ulcers. Tight, hairless skin, okay, as shown here, the hairless skin here. The toes are tapering. The leg pain at night, usually they have pain even at rest, especially even at night, which prevents the patient's sleep. No bleeding. Rarely there's bleeding because there's not much blood supply. Affected area is cold and maybe clammy. Leg ulcers redens when the tangled and turns pale when elevated. This will be the just sign. Okay, so this pictures summarizes the clinical features of chronic arterial disease. Okay, now I describe to you what is the Burgess test. Burgess test, patient is lying supine, raise the foot and leg to 45 degrees or less, watch the leg becoming pale. Ask the patient to sit up and hang the leg at the foot end of the bed. Legs become blue, then red. It's a positive test. Okay, hyperemic. hyperactive hyperemia. Okay, here the leg is elevated to about maximum 45 degrees, so the leg becomes pale, the foot becomes pale. Angle at which the limb goes pale is known as the Burgess angle. How many degrees from the horizontal? Here, when you after that ask the patient to hang the leg down, and then the leg becomes straight. Okay, hyperactive hyperemia, rubor, pallor and rubor. Okay, so these are the signs here. Pallor here, elevation of leg, then you hang the leg, becomes straight. Okay, same thing. Pallor, when you elevate the leg, that becomes pale, and when you hang down, becomes hyperactive uh, hyperemia.
Berger's test is an important test in physical examination and clinical research, which is used to assess the adequacy of arterial supply to the legs. Examination sequence: with the patient lying supine, stand at the foot of the bed. Watch for pallor with emptying and guttering of the superficial veins. Ask the patient to sit up and hang their legs over the edge of the bed. Watch for reactive hyperemia on dependency. The loss of pallor initially and spreading redness make a positive test.
Okay, there's another special syndrome known as the Larry-K syndrome, which is due to obstruction of the bifurcation of the aorta into the iliac arteries here, as shown here. Aorta, right and left iliac arteries. There's a blockage here, narrowing due to atherosclerosis. And Larry-K syndrome is a form of peripheral artery disease affecting the aortic bifurcation. The severe stenosis affecting the distal abdominal aorta, iliac arteries, and femoral-popliteal vessels. It is specifically present with the triad symptoms, triad, which is pain in the buttocks or thigh, which is claudication pain, erectile dysfunction and impotence, and absence of femoral pulse. Okay, here you can see the obstruction here. Okay, next we come to critical limb threatening ischemia. Critical limb threatening ischemia is the advanced form of chronic limb ischemia. It can be clinically defined in three ways. First, ischemic rest pain for more than 2 weeks, requiring opiate analgesics. That means he's in pain, severe pain for some time. The presence of ischemic lesions, such as ulcers or gangrene, objectively attributable to the arterial occlusive disease. And thirdly, the ankle brachial pressure index less than 0.5. On examination, the limbs may be pale, cold, and weak or absent with absent pulses. Other signs of this patient include chronic limb ischemic signs such as hair loss, skin changes such as trophic skin, ulceration, or gangrene, and thickened nails and trophic changes. These are the called trophic changes of chronic limb ischemia. Okay, critical limb threatening ischemia. On examination, the limbs will be pale and cold, weak or absent pulses, and other signs include loss of skin, hair loss, skin changes, smooth skin, atrophic skin, ulceration, gangrene. In this patient, there's massive gangrene of the toes here associated with skin changes as well as thickened nails here. Okay, very severe trophic changes. The differential diagnosis for chronic limb ischemia. There are two major differential diagnoses for a patient presenting with limb ischemic symptoms. First, spinal stenosis, acute limb ischemia, deep vein thrombosis, thrombophlebitis, and trauma. Okay, these are the differential diagnoses. In spinal stenosis, which is also known as neurogenic claudication, typically the pain is from the back radiating down the lateral aspect of the leg in the area of the tensor fascia lata. Often, they have symptoms on initial movement or symptoms that are relieved by sitting rather than on standing. The rare causes of non-atherosclerotic lower limb ischemia include popliteal artery entrapment syndrome, persistent sciatic artery, ileal endofibrosis, cystic adventitious disease, and Buerger's disease. Now, what are the investigations that are required for these patients with chronic limb ischemia? The diagnosis of chronic limb ischemia is basically clinical. I must remember this, but sometimes certain tests have to be done in order to confirm and establish the severity of the disease. Okay, and this the most important examination that can be done is a systolic pressure ankle brachial pressure index, ABPI. Okay, which is the ratio of the systolic pressure at the ankle to the systolic pressure at the brachial artery in the elbow. Okay, the severity is graded like this. Normal, the ABPI will be more than 0.9 to 1.1. Mild disease will be 0.8 to 0.9. Moderate is 0.5 to 0.8, and severe disease is less than 0.5. If ABPI of more than 1.2 should be taken with caution, as it may be a false positive due to artery rigidity due to calcification of the artery. It's important to remember that the API value of more than 1.2 should be interpreted with caution, as calcification and hardening of the arteries may cause a falsely high ABPI.
So now I'm going to do an ankle brachial pressure index. This starts by taking the systolic blood pressure in both of the arms and using the highest of those numbers, then attaching a simple manual sphygmomanometer to the lower leg and using an arterial Doppler scanner. Start by locating a pulse. Pump up the sphygmomanometer to above the systolic pressure and then gently release that pressure, listening out for that first blush of flow. And then repeat that multiple times like this. So again, around the 140 mark. Okay, then to calculate the pressure, just simply divide the pressure in the foot, which is the highest of the two numbers, by the highest of the pressures in the arms.
Okay, what are the other special investigations that can be done for these patients or should be done? First is your Doppler ultrasound, which is used to assess the severity and anatomical location of any occlusion should be undertaken. So very important to do a Doppler. All patients must be subjected to a Doppler ultrasound to assess the site of the obstruction, presence of obstruction, and the severity of the obstruction. Next one is your CT angiogram, CTA, which is very, very important in patients who may want to be deciding whether you want to go for surgery or otherwise. And the other one is your magnetic resonance angiography. It's becoming more popular these days, MRA.
Now, due to the concurrent cardiovascular risk factors seen in patients with chronic limb ischemia or chronic limb threatening ischemia, patients should also have a cardiovascular risk assessment. These include pressure, blood glucose, lipid profile, and ECG. A full cardiovascular assessment of the patient should also be done. In addition, any patient presenting with chronic limb threatening ischemia who are less than 50 years of age without significant risk factors should also have a thrombophilia screening and homocysteine levels checked. Okay, this is for patients who are less than 50 years old, have got no cardiovascular risk, no other risk factors. So the homocysteine levels should be also be checked. And this lower homocysteine level has been associated with reduced risk of cardiovascular defects. So very important. So patients, old patients, you must assess the full cardiovascular screening. Younger patients, you must also do a homocysteine levels. Now we come to the final part, the management of these patients. There are two, medical management and surgical management. Most patients with chronic limb ischemia require cardiovascular risk factor modification, assessment and modification, which I mentioned just now. Lifestyle advice, smoking, stoppage of smoking, very strict, regular exercise, and weight reduction. These are all very important. Statin therapy, ideally atorvastatin, 80 milligrams daily, is very, very useful to reduce the uh, lipid levels. Antiplatelet therapy, ideally you use clopidogrel, 75 milligrams per day. And some patients use other forms, milder forms of blood thinning, such as aspirin, which is cardioprin, which is 100 milligrams daily. And very important for you to optimize the control of your diabetes. Very, very important. If a patient is diabetic and hypertensive, this must be controlled. And this patient should always be enrolled in some form of exercise program to improve their walking distance and claudication distance. And should be used as the first-line therapy in any patient with critical limb ischemia. All patients with critical limb ischemia or even in mild forms of limb ischemia, they must improve with exercise, and also the claudication distance must improve. So patients walking is a very, very important exercise. The cause of chronic limb ischemia is variable, and most patients' symptoms do improve on lifestyle changes and medical management alone. Most of the patients will improve to some extent. Okay, it is important to encourage this patient to walk through the pain to encourage the development of new blood vessels. Exercises develop or new collateral circulation to establish new blood vessels, which establish a new collateral circulation, which will improve the circulation from the limbs. Okay, now what are the surgical management that is available for these patients? Okay, first, when do you refer the surgery? When do you consider surgical management? Okay, two main conditions. One is failed medical treatment. When all this controlling of the risk factors and all the conservative measures that you have mentioned just now, if all of and the medications and fail, then you have to consider the patient for failed treatment. Or if the patient's condition becomes worsens from chronic limb ischemia develops critical limb ischemia, then you need surgical intervention urgently. Okay, so this will be the two main indications. So the by far most common is your failed medical treatment. There are number of methods of surgical options for these patients. First is that the traditionally used is the endoscopic thrombolysis and endarterectomy, which is giving way to the newer methods, angioplasty with or without stenting. And if this fails, then you go for bypass grafting. Okay, bypass grafting, especially if the disease is more diffuse and in younger patients. Of course, failing all this, if the patient develops severe infection, gangrene, then there's no choice. Then you have to go for some form of amputation.
Okay, this is angioplasty. Okay, this is the cross section of the artery here. Okay, this is the plaque here. Okay, causing atherosclerotic plaque, narrowing of the lumen. So you introduce a stent here, and this stent endoscopically, and this will then dilate the artery, steno's part, and thereby improving the blood flow. And sometimes you also can do endarterectomy or thrombolysis through this method, angioplasty method itself. Okay, here's your compressed plaque here. So as a result, the blood can go off flat. Here, this is the artery bypass. Okay, take for example, this is the lower limb. There's a block here in the femoral artery. Okay, there's a block in the femoral artery here. So what happens? You bypass the artery. Use a graft. You bypass from before the block to after the block. So this is known as an artery bypass graft or stent. Okay, so this is for diffuse disease, and in younger patients, this will be useful. For isolated blockages, then this may be useful in this patient. Okay, what are the complications, outcome, and prognosis of chronic limb ischemia? Okay, chronic limb ischemia can develop secondary sepsis. Okay, especially in patients with ulcer and gangrene, and this can lead to septicemia and death. Can lead to acute on chronic ischemia, which will be talked in the next lecture. Can lead to amputation of the limb and reduce mobility and quality of life in patients, especially if the patients are young. Over a 5-year period, the intermittent claudication, what happens? What's the future of these patients? Most of them with stable claudication will improve. Okay. However, 10 to 20% of them develop worsening symptoms. From claudication, they may go into limb ischemia, chronic or what do you call acute limb ischemia. Okay, that's another thing. And 5 to 10% develop critical limb ischemia. 2 years following the below knee amputation for patients with chronic limb ischemia, what happened? 15% of them require further above knee amputation. 30% of them died, and only 40% have full mobility. So the full mobility is only 40% in the majority of patients. The 5-year mortality rate for those diagnosed with chronic limb disease is around 50%. It's not only from the limb ischemia, it can be from other cardiac events. Amputation is eventually required in 1 to 2% of all cases with chronic limb ischemia. And this figure is higher, 5% in patients with diabetes. Now, finally, the key points. What are the 4 key points to take back? Chronic limb ischemia is a common condition ranging from severity across the population. It is associated with several cardiovascular risk factors. While clinical diagnosis, it can be it's a clinical diagnosis, it can be quantified by ABP, ankle brachial pressure index testing, followed by imaging. And this imaging include angioplasty and Doppler ultrasound and CT scanning, CT angiogram. Surgical intervention can be offered if conservative management fails, or for those who presenting with critical limb threatening ischemia. Okay, two conditions. Medical failure treatment fails, and if he develops worsening condition going on to the critical limb threatening ischemia. The 5-year mortality rate for those diagnosed with chronic limb ischemia is around 50%.